All right. I'm going to share my screen. We have two chapters to get through. They're not very long, but still want to make sure we have enough time. And then if we have time at the end, like I said, if you want, we can go through the test. Okay. Um, let me see. Okay. Let's get this one up. All right. Can everybody see my screen?
Yes.
Okay, perfect. So the drugs that we're doing today are going to be our GI drugs. Okay. Um, so these ones are going to be our acid drugs. So more of like our like pepsids and Zofrans would be like more the next chapter. Okay. So let's start this one. What is this term to see that?
You breaking up.
What does the term gastric hyperacidity mean?
High acid in the stomach.
Yep, high acid in the stomach. What would be conditions that would cause that?
GERD.
GERD. Okay. What else? Ulcers.
Yeah, like peptic ulcers.
Yep. So GERD, peptic ulcers, any type of stomach cancer or esophageal cancer, those would be like your big ones. Okay. When you do get too much acid produced in the stomach, those are usually going to be produced. What you're going to have is more hydrochloric acid. That's going to be what the actual acid is. Okay. Sound familiar? Okay. Um, and then those are produced by the parietal cells in the GI tract. Okay. Just let me know if I go out. All right, please. And then I will repeat what I said. Um, but again, in the stomach, hydrochloric acid is produced by the parietal cells. That's just a start. All right. Questions there. Okay. This part's really
You're
important
going out.
is what do you think most of these mechanisms of action are going to affect? Okay. I
You
said
w-
this part's really important because what do you think most of the I'm sorry?
You went out again.
Okay. I'm not even having a problem with my Wi-Fi today. Um, okay. Um, can you hear me now?
yeah,
Okay. These parietal cells are really, really important because that's what is going to mostly be affected by the drugs. Because again, they're for too much acid, right? And these are what produce the acid. Okay. We go with that.
yeah.
So, so make sure that you're familiar with this name and that what they're producing is hydrochloric acid. Okay. And that's the acid that would destroy my cells. Okay. Also, are we aware that it destroys pathogens? Because what happens when you swallow a pathogen?
It caused bacteria.
Well, when you swallow a pathogen, then it enters your bloodstream through your GI tract, right? So once it gets to the stomach can destroy it with the hydrochloric acid before it can get into your bloodstream from the GI tract. Does that make sense? Okay.
Yes.
Yeah, so that's just another function of hydrochloric acid, just to be familiar with that. The stomach also has bicarbonate. Does anybody know what that is? Bicarbonate.
Is it related to the carbon in your blood?
Um, in a sense, it's the opposite of that. It has to do with my ABGs.
Yeah, that's related to like your pH, your
Yeah, this would be
metabolism.
my yeah, this would be my alkaline substance in my blood.
So it's related to your metabolism, right? The
Correct.
bicarbonate.
Yep, yep.
Okay, there you go. Okay.
Yep. Yeah. All right. And it causes a base reaction. So, or my alkaline. So if I have a lot of stomach acidity, if I raise the bicarbonate levels in the stomach, would that kind of even out or neutralize some of the acid?
Yeah.
Okay. So you'll see that again. So pay attention to that. And then don't really care about this too much. This right here is important because remember when we talked about pernicious anemia? Remember when we talked about that? What is
That's
pernicious?
related to B12.
Yeah.
Or when
Yeah, it's autoimmune. It's related to B12. And how it happens is because these factors, they're needed to get the vitamin B12 that I swallow and that I eat from my food into my GI tract. I can't absorb them without it. So this autoimmune disease with pernicious anemia destroys my intrinsic factors. So if I don't have,
I'm sorry to interrupt. Your
yeah,
slides, on the right thing, hyper is, yeah, it has like the extra that you have highlighted can lead to pernicious. Like that's not on ours.
I
Yeah,
know I'm
it's not.
highlighting it as I go.
It's what did you say?
I'm highlighting it as I go.
I know that, but what I'm saying is the printout that we have is different from what you have.
Is it?
Like, yes, that part, it's not on our slide.
That it
What
can
you
lead
have
to pernicious.
destroyed by the immune all of that is not on there. It just says the intrinsic factor. That's my part. Then it goes to the mucus part.
Okay. I might have had an updated version right now. This is the one that I emailed you though. I apologize about that. I must have updated
Mhm.
it and sent you guys
Okay.
the older copy. So just either write it in on your PowerPoint or just pull up the one from your email. Okay, I apologize about that. All right, but everybody understands what I did? I'm sorry.
Yeah.
Okay. But just I know there might have been just a few things that were added. I don't think I changed a lot of it, hopefully. Um, but does everybody kind of understand how pernicious anemia happens?
yes,
Okay. Um, so also we have the mucus. What is mucus for in the stomach?
Protect the stomach.
Yep, it helps protect that stomach lining because the hydrochloric acid is like basically coming into my stomach every day, right? Multiple times a day as I eat. So something has to protect that stomach lining so that it doesn't eat away at it, right? And that would be the mucus that kind of produces like a protective cover. Okay. Um, and then who remembers what my prostaglandins are?
Ain't that's the ones that prostaglandins come from COX1 and COX2. They are the long-acting inflammatory response.
You are correct, ma'am. Yep. And they kind of act like histamines. Like histamines and prostaglandins kind of work together to cause inflammation. Okay. Do we have any questions about anything that's on this slide?
You were going out about the intrinstic factor. Can you go over that one more time?
Yeah, sorry. The intrinsic factors, those are something that is in the stomach. They're part of just like another type of cell. They are there to help absorb the vitamin B12 without kind of like if you attribute this back to like our fat soluble vitamins, I can't absorb the fat soluble vitamin without the fat, right? So this is kind of the same thing. I can't absorb the vitamin B12 if I don't have my intrinsic factor. Okay. So what pernicious anemia does is it's an autoimmune disease that destroys my intrinsic factors. Um, so then if I destroy my intrinsic factor, can I get the vitamin B12 from my food?
No.
And then I would be low on vitamin B12, right? Which helps produce hemoglobin in red blood cells. And then I'm low on red blood cells. Does that make sense how you get to anemia from that?
Yeah.
Okay. Does anybody have questions about the intrinsic factors or the pernicious anemia? No.
No.
Okay. Okay, perfect. Otherwise, I think that was pretty much it. Again, I just went over this because these will be my mechanisms of action. Okay. So I will go ahead and go to the next slide. Um, Okay. Again, these are the big conditions that we are treating with these medications that help reduce acid. We said GERD, we said peptic ulcer disease, GI issues like cancer, any kind of lesions that are in there. Okay. And then who can tell me what H. pylori is? That might not be on your slide, but what is it?
It's a dangerous.
Infection
It is an infection.
in the
It's
stomach.
Yeah, it's a very, very stubborn bacteria that burrows itself into your stomach lining, so that it's really, really hard to kill. Does anybody know how many days we have to like take antibiotics for? Just as like not an exact, but is it a long time of antibiotics?
That kind of like C. diff
Yeah.
or no?
Is it kind of like what? Sorry, did you say
C.
C. diff?
diff? Yeah. No.
No, because C. diff is an opportunistic infection.
No.
This is just a really, really stubborn bacteria, but they are both from bacteria, so in the GI tract, so that's a good connection. Okay. Any other questions, concerns about this? Okay. Otherwise, I don't really. Sometimes you need to take antibiotics with proton pump inhibitors, which is one of the meds we're going to learn about, because it kind of helps get rid of that stomach acid so that we can kind of get to the stomach lining more. Okay. Good there? All right.
Yeah.
So these are going to be the three types of drugs that we're going to learn about: antacids, H2 blockers or H2 antagonists, and then PPIs or my proton pump inhibitors. Okay. So let's go to the first one. This is going to be my antacids. What's your biggest example of an antacid that just comes right to your mind as soon as I say it?
Omeprazole
Famotidine.
or Tums.
Tums, yes, Tums. Yep. Hold on to the famotidine and the omeprazole. We will get there. Okay.
Oh yeah, those PPIs, aren't they?
Yes, we will get there. Yeah.
Okay.
And they're the H2 blockers. And then the Zofran we will get to in the next chapter. Okay. I know you didn't say that, but I heard that one earlier. So, all right. So why are we taking an antacid to help with what?
Get rid of the acid. That's
Yeah, my like too much acid or my heartburn, right? Because what is heartburn? How is that related to too much stomach acid?
that back up in the esophageal.
Exactly, right? And causes like burning, upset stomach, okay? So a lot of these I want you to know are made from these three right here. What are these considered?
Can you
The ones
repeat
that I
that?
highlighted? Yep. Most antacids are made from aluminum, magnesium, and calcium, which are all minerals or electrolytes. So do you think, what kind of problem do you think that that's going to cause? Without me even having to tell you.
Like abnormal labs or
Yeah, of what?
Electrolytes?
aluminum, magnesium, and calcium.
I could. And what if I already have like a magnesium imbalance?
Can it lead to seizures?
It could. Yep.
That's sodium. Okay, I'm thinking of sodium.
No, but
Muscle?
other
Are you talking
electrolytes
about
can too. Yes. I am talking about,
cardiac?
No, it
it
could
could,
lead to muscles.
yeah, there's a couple different things that can happen with magnesium and calcium, but basically it can lead to an electrolyte imbalance. Is basically just the main thing I was going to get at. Sound good? We just leave it very base level. And then you should not use ones made with magnesium if you have renal failure. Okay. That's like a huge contraindication. Don't use them if they have renal failure. Okay. How do these work is they neutralize the stomach acid. Okay. They neutralize the stomach acid. They do that by basically, how do I want to word this one? They help basically what's going to neutralize it. So if you have, they don't actually stop the acid from being produced, but what would be a way to kind of balance it out? We talked about it in the first slide.
The bicarb.
The bicarb, right? So it neutralizes it by using the bicarb. So what is this going to do to the bicarb? Raise it or lower it?
Raise it.
Raise it. Okay. So that is going to be its mechanism of action. One, it's made from electrolytes. Two, it helps raise my bicarb. Okay. To help kind of balance out or kind of reduce the effectiveness of that acid. Questions there? Okay. So you can stick a big bicarb sticker right there. Okay. And then my contraindications. What was the big contraindication we just mentioned before? I won't hear it back.
The renal
Kidney issues,
With which electrolyte?
magnesium.
magnesium.
Okay. Yep. So that's a huge contraindication. All right. Also, if you just have renal failure in general, okay, you should not be taking this, okay, because the electrolytes, even if it's not magnesium, can just be hard on the kidneys, okay? Because what is in charge of getting the electrolytes in and out of the body, or sorry, out of the body, which would be the kidneys, right? So
Yes.
again, yeah, so any kind of renal issues may affect your electrolyte levels, which could make this unsafe. Okay. Um, and then if you have an electrolyte imbalance, so that would be more like if I had high calcium, would I want to take one that's made of calcium?
No.
No, right?
No.
Because that could get too much. Okay. So keep that in mind. And then a GI obstruction. Okay. So what do we know about GI obstructions? Have you learned about that in Med-Surg 3 yet?
It's a blockage.
It is a blockage. So nothing's really moving forward, right?
Hmm.
So do I really want to give, so these antacids may unintentionally irritate the stomach and actually make things move. So I don't want that to happen if I have a bowel obstruction. Does that make sense? Questions, concerns?
You say you don't want to give it if you have a bowel obstruction?
Yes.
Okay.
Because it'll make it move.
Yep. Because the antacids can kind of stimulate or aggravate that peristalsis sometimes. That's like an adverse effect, and it could push things through, right, with the peristalsis being aggravated. And if I have a GI obstruction, I obviously don't want to move things, right, because it's very touchy. Okay.
So is that the overall reason that you're giving an antacid to move things through to like get that acid up out the body?
Um, Not in a sense. We're not trying to get rid of it. We're trying to, in this sense, counteract it. This is just kind of like a extra thing that it does. It's not part of why we're taking it.
Okay.
Now, you saying that the obstruction is a blockage, right? I mean, it might be a little bit touch and miss, sir, but when you want the blockage to move so they won't have the obstruction,
Yes and no. The goal is for it to be moved, but if enough of it has been like backing up and it's kind of like this big bulge that's in there, it could do more harm for it to move forward, especially if we're trying to like suck it up through an NG tube or have to surgically remove it.
surgically remove. Okay, that was gonna be on it. All
Yeah.
right.
Yeah. Okay. Yep. Especially, yeah, with this surgical intervention. Yep. So you are correct, ma'am. You got the nail on the head there. Okay. So contraindications, why we're taking it, and mechanism of action makes sense.
Yes.
Okay, good. I just want to make sure no one had any questions. So if we move on to my interactions, what do Tums interact with? If they can reduce the absorption and the excretion of some medications, that could be a problem. We know that Tums sometimes can be like iron or milk, where they can coat the stomach and they can actually kind of make it harder for drugs to be absorbed. Have you ever heard that before?
You
Yes.
said milk do?
Milk does it, iron does it, and then antacids can do it. So they actually
Okay.
affect a lot of the medications getting into my bloodstream from my stomach.
I
When
knew milk did. I didn't know iron or.
yeah, iron does for sure. Yep.
Okay.
Okay. So it can reduce the absorption of some medications. Okay. And those medications are usually going to be your benzodiazepines. So those would be my like Xanax, Valium, Ativan, right? If I'm delaying the absorption of that, that means there's going to be more left in my stomach and it's still going to be trickling into my bloodstream. And then I take the next dose. So what am I at risk for?
Toxicity.
Toxicity.
Yep. Toxicity. Okay, so toxicity of benzodiazepines could result in what?
CNS depression.
Yep, CNS depression, which could equal what?
Overdose.
Overdose, coma,
Altered LOC.
yeah, drop in LOC, coma, seizure, respiratory cardiac arrest. Okay. And then who knows what a sulfonylurea is? What type of medication is that?
Anti-diabetic.
Yep, that is an oral anti-diabetic medication, kind of like the same type of is your metformin. All right. These, if I have toxicity of this, what could happen too much? Too much sulfonylurea will
Would
do
be
what?
hypoglycemia.
Yeah, it's going to go hypoglycemia, and then it kind of have the same problem, right? CNS depression, coma,
Yeah.
seizure. Okay. And then what's valproic acid? Do you remember what this is?
That's for
A
seizures,
seizure.
ain't it?
Yep, that is for seizure. Okay. So if I have toxicity of that, do you think it's going to affect the way that that treats my seizures?
Yeah.
Okay. So that's not going to be a good thing, right? Because I'm relying on this medication to make sure that I don't have one, right? I don't want to mess with that. Okay. All right. So that is kind of what's happening here. These drugs right here are just some of the examples of the absorption can be delayed, causing toxicity. Okay. Don't worry about this middle bullet point. I'm not going to worry about that. I just kind of want you to know the absorption thing. We good there? This one and this one. Okay. All right. So my adverse effects. Magnesium can cause diarrhea. Okay. Magnesium can cause diarrhea. Calcium can cause kidney stones. Why does calcium cause kidney stones?
That's what the kidney stones are made of, is calcium deposits.
Yep. Because if I take a calcium-based antacid, I could give myself hyperkalemia, too much calcium, or sorry, hypercalcemia, and then that potassium has to get out of my body. It goes to the kidney, and it just, there's way too much in there before it can actually be made into urine, and it starts to clump. Okay. Questions about that? And then, like I said, you can get electrolyte over imbalances. So again, with the calcium, magnesium, I can get too much. Okay. I could get alkalosis. What would be an example of that? Systemic alkalosis. Goes back to the bicarbonate, right? Because that's what we're dealing with here. Have we heard of metabolic alkalosis? So it would cause that. Yeah, it would cause that. Okay. And then if you use antacids for a really, really, really long time, all right, it can mask symptoms of a bleeding ulcer, okay, or a stomach cancer. All right. So if you take NSAIDs for years and years and years, you may not get all the symptoms of a bleeding ulcer or a stomach cancer. So you could not know something was wrong. It could go misdiagnosed. Okay. Questions about that? That's why we don't take antacids for a long time. They're more of like a rescue treatment when you have heartburn versus something I would take every day. Okay. We good there? Okay. These come in a lot of different formulations. We know usually you take them in chewable, right? You can also swallow them, come in powders, right? And then these are most of your names. I do need you to know all the names on this list, okay? Because are all of these familiar?
Yes.
Okay. Which one? I know Tums is going to be the most familiar. Probably Malox, Milk of Mag, right?
Milk Man, Alka-Seltzer.
Yeah, Alka-Seltzer. Basically, all of them are pretty familiar. So just make sure that you know all of these. Okay, fair enough. They're pretty common anyways. Okay. Any questions about antacids? We good?
So just to make sure I'm understanding, the N-acids is made up of aluminum, magnesium, and calcium-based formulations. So
Yes.
that's why the adverse effects can be magnesium formulations causes diarrhea
Yep.
because it's made up of that.
Mm-hmm.
Got it.
Yeah, not so much the aluminum. That doesn't really cause too many adverse effects. It's mostly the calcium and the magnesium. Okay. Any other questions? Okay. The only thing that I really want you to know about this one, an anti-flatulent is an anti-gas, right? I really just want you to know that the name for most anti-gas meds is simethicone. Okay. All I need you to know is that name. Good? All right.
Yep.
No other stuffs here. Okay. This one may have a couple extra slides that aren't in your PowerPoint. I added like 1 or 2 slides to this, but then the rest should be the same. The next ones are going to be H2 blockers. But before I go to that, I want to tell you what an H2 receptor is. What uses my H1 receptors? Those you probably
Your
didn't.
histamine?
Yeah, I don't know if you talked about it in Farm 1. But yeah, your histamines are going to land on your H1 receptors. Okay, so any type of allergic inflammatory response that involves histamines is going to land on those receptors around the body. Okay. But then we have these weird little H2 receptors in my stomach. Okay. Do they necessarily have to do with histamines? A little bit, because sometimes when you eat, you also release histamines.
I'm so
Okay.
confused. The PowerPoint that you gave us is different.
I know.
Okay. Okay.
Yep.
Sorry. Sorry if that's already been addressed.
Yeah, yeah. So yeah, just the ones I emailed have all this. The ones printed out do not.
You breaking up.
We can't hear you.
Is she paused?
I can't see you either, actually.
I think she's
Okay, I'm back. I apologize. All right. I apologize for the interruption. Is everybody still ready to get back to where we were?
Yes.
Okay. Again, I apologize. Let me share my screen. All right. Everybody can see my screen here with chapter 50.
Yes.
Okay. Sorry, let's resume here. Okay, so like I was saying, you have two different receptors for histamines. Okay, one receptor is used when it's released for immune responses, infections. Okay, the other one is located in the stomach. Histamines are also released from the brain when you eat, telling the stomach that it's time to make hydrochloric acid. Okay, does everybody understand that? Okay. So the ones in your stomach, by blocking them, I'm going to stop the brain from telling the hydrochloric acid to be produced, therefore lowering the amount of acid. Okay. Does anybody have questions about this?
Repeat that.
Yeah. So when you have histamine ones, those are located all over your body. They release or they get histamines landing on them in whatever area that you have an infection, causing your inflammatory response. But then you also have H2 or the second type of histamine receptors that are located in your stomach. And when you eat, your brain releases histamines, sending them to your stomach saying you need to make hydrochloric acid. Questions about that? So then these medications are H2 blockers. So they're going to stop the histamines from the brain to be able to basically land on those receptors in my stomach saying make the hydrochloric acid. Okay. If you have questions or concerns about that, does that mechanism of action make sense?
So are you saying with the H2, when it's blocking, it's telling the brain to not make the acid, correct?
It's not telling the brain, it's the histamines from the brain are coming to tell the stomach, hey, make hydrochloric acid. But when basically the medication is going to sit on those receptors so that the histamines can't send the message to make it. So therefore, less is made. Does that make sense?
That makes sense. So when it tells it to do that, do the stomach become more alkaline?
By default, yeah, because it's not going to have as much acid being produced.
Okay.
Okay. Yep. Good thought there. Any other questions about this? Because this is kind of the mechanism of action here. Again, it's going to block those H2 receptors so that we don't make my hydrochloric acid. Okay. And then by doing that, yes, we increase the pH, making it alkaline or basic. Okay. So the other type, my antacids, actually just release more bicarb to make it more basic. Here, we're taking down the acid level to make it more basic. Questions or concerns about that? Okay. And we're basically taking it for the same reasons: GERD, ulcers, issues in my esophagus, issues in my GI tract that would not benefit from too much acid. Okay. Um,
Sorry to
allergies are,
interrupt. Is it still recording?
yes.
Okay.
Yes. Yeah. It just took a down time when I was dealing with the Wi-Fi, but it is still recording. Allergies are a forever contraindication, so that is a given. And then if you have liver or kidney failure, I'm not saying that you can't use this, but you would definitely need dose adjustments to make sure that you don't hurt either organ. Okay. And then when it comes to my interaction, and I'm smoking, the nicotine and all the chemicals in the cigarette is going to make the H2 blocker less effective. Okay, so if you want this medication to work as well as it can, then don't smoke with it. Okay. Also, it's going to inhibit the metabolism of these meds right here. So, what does it mean if I inhibit the metabolism of something?
You're
Stop
gonna
it.
stop it from breaking down.
Yeah, it's going to stop it from being broken down before it goes to the kidney to be urinated out. So, basically, what is that going to lead to? Higher levels, right? That circulate my bloodstream. And then that's going to lead to potential what?
Toxic.
Yep, toxicity. Okay. What's going to happen when I have too much warfarin?
You can bleed. Can't you bleed
Blood.
out?
Yep, you can bleed too much. What about phenytoin? What type of med is that?
Is that for
Is that a
seizure?
seizure medication?
Yep, it's for seizure. So again, if I have too much of this in my body, it's not going to help the seizures as much as it should have. And then what about lidocaine?
Pain.
Mm-hmm. Does anybody else know what lidocaine can be used for besides pain?
Numbness. Like if you was to get a spinal.
Isn't it an anti-dysrhythmic?
Yes. Yep. So it's used for pain and it is used for dysrhythmias. Okay. Like examples of dysrhythmias are AFib, right? VTAC, things like that. So very good. Thank you. So do I want to mess with the levels of this? Especially if I'm using it as a dysrhythmic?
No.
No. Okay. So do we understand the interactions?
Yes.
Okay. No one has
So
any other
Miss
questions or
Hyde,
concerns about this
I
slide?
do. I do. I just want to make
Yes, ma'am.
sure I'm getting what you're saying. So you're basically saying that it'll stop the breakdown of these meds, and with it not being as effective, we will have, like, further complications of possibly bleeding, seizures, pain, and or dysrhythmias.
Yes,
Like
because
these meds won't be effective because this is inhibiting the breakdown of it.
yes, and by stopping the breakdown, we're going to have higher levels of these meds in the body. So that's where you get the issues.
Okay, thank you.
Yep, because they're going to be dangerous levels. Okay. Any other questions? I want to make sure nobody has any questions or concerns.
So the block the H2 receptor, that mean that it's sitting on that receptor from going off and telling it to make more. Correct.
Yeah, well, it's blocking that receptor so the histamine message can't land there and say, hey, and tell it what to do. Hey, make more.
So it's like something guarding the door and not
Correct.
letting it in. Okay.
Yes. Thank you. Yeah, it is guarding the door. That is a great analogy so that the messenger can't come in and tell it what to do. Yep. And the medication is acting like the guard. Okay. We good with that? Great analogy. Okay. So we are therefore making less acid. Okay. My adverse effects here, there are quite a bit of them. So I have kind of grouped them by system, hoping that that'll kind of, I know it's not going to help, but it may may help reduce some of the anxiety with it. I don't know. But do I want anything to cause hypotension?
No.
No. All right. And then I know I'm skipping ahead, but if you go down to right here, increased BUN and creatinine and increased liver enzymes, what issues does that cause? What is going on with that?
It could cause liver failure.
Liver failure and kidney failure, right? Anytime that the liver enzymes, which are your AST and ALT, are elevated, or anytime your BUN and creatinine are elevated, that equals kidney and liver issues. Okay. Did we hear the word kidney and liver before with this drug? Did we see it here?
Yes, we did with magnesium issues or something like that, right?
That was the other one. So I'm glad you remember that, but wrong one.
Okay.
Yeah, yeah. So just again, make sure you keep track of that. But yeah, these are contraindications: liver and kidney failure. All right, need special dosing requirements because again, these are the adverse effects. Okay. Questions there? Okay. What is gynecomastia? Not a huge adverse effect, but does anybody know what that is?
When men
Like a
You,
left
you
breast.
have
Yep, when males grow breasts. Okay. We got the hypotension. Look at all the CNS stuff it can do. I'm not super concerned about headache, but again, like fatigue, confusion, depression, hallucination, slurred speech, agitation, are these all kind of concerning?
yes.
Yeah, so I would definitely know these ones. Okay. Know the hypotension. And then the GI effects, are these pretty normal for any type of medication, nausea, diarrhea, cramping? I know they could be bad, but they're not. They're kind of like the headache, right? They're not going to kill you, per se. So I'm not super concerned about those right this second. Um, Same with alopecia. What is that?
Hair loss.
hair loss condition.
Hair loss, right? And rash. So I know those can be kind of concerning, but are they going to kill me? No, right? This is what's going to kill you. This is another one that can kill you is your hematological. So decrease white blood cells, decrease platelets, and decrease white blood cells. Is that an issue? And why?
It can lead to infection risk.
Yep, infection risk with the decreased white blood cells. What about the decreased platelets? What's that going to do?
Bleeding.
Okay, and what about the decreased red blood cells? I know anemia, but what could happen if the anemia gets really bad?
Low
They have shortness of
perfusion.
breath.
Yep, low perfusion, yeah, shortness of breath, cardiac arrests, shock, right? And a lot of bad things. Okay. So does anybody have any questions about these adverse effects? Okay. I know we don't use Zantac anymore, but Zantac would have been a version of this med. It has been recalled. However, the most common one that you're probably used to seeing again is famotidine or Pepcid. All right. And then maybe has anybody heard of Tagamet? I know that's not really a common one. No. Well, just make sure you know the Pepcid and the famotidine. I need you to know both names. Okay. Fair enough. Just one drug name there. Okay. All right. Any questions before we move on to PPIs or my proton pump inhibitors?
I do have a question.
Yes.
So I
Yes.
noticed on this past test, I think I was kind of like studying wrong because when I went back over the lecture and I was getting so familiar with the names, but it was more of the classes being used. And I think that's what kind of tripped me up there. I was kind of studying both, but it was like the drug names that were so similar to each other. I really had to get a grasp of.
Okay. No, and that's fair enough. Yeah. So I tended some or SurePath. I mean, I don't write the questions, but SurePath does tend to use one or the other or sometimes both. So yeah,
Okay.
definitely be familiar with them. Yeah. Yeah, because the NCLEX SurePath, they tend to use both names. Okay. Yeah. Always good to know the class where something comes from. Okay. All right. So PPIs are proton pump inhibitors. We're not going to get super crazy into how this works. However, we're taking it for the same exact things, except with the addition of my H. pylori. Okay, because remember in the beginning I said that you could take this with H. pylori. You need antibiotics and the PPI. Okay. So what this does is it literally just stops the parietal cells from making as much acid, okay? Stops the parietal cells from making as much acid, okay? We don't need to know how it does that because it's a whole long thing. However, it can stop making up to 90% of its acid. So that's pretty effective, all right? It almost makes it produce no acid for the amount of time that it works, usually over a 24-hour period. So anybody have any questions about that? So this one is way more effective than the other two. So if I had to pick one out of the three, a proton pump inhibitor is way more effective at treating these disorders than an H2 blocker or an antacid.
No.
Okay. And then again, no contraindications here. Allergy is a forever contraindication, so we don't have to worry about that. And then my interactions, okay, there's a couple here. And yes, I do want you to know these three, okay? If I take a proton pump inhibitor with warfarin, okay, it's going to make the warfarin more effective, okay? It's going to make the warfarin more effective. However, when I take it with Plavix, it's going to make it less effective. So kind of, I know they're both different types of blood thinners, but it's going to make warfarin more effective and Plavix less effective. Okay. And then it's also going to make diazepam, which is a benzo. I think it's also Valium. And phenytoin, which is a seizure med, increase in their levels. So it's going to make them toxic. All right. So again, I have to worry about the seizure medication that works as well, and maybe benzodiazepine toxicity or overdose from the benzo, which could cause again like the drop in the CNS depression. Any questions about these interactions?
Yes, can you repeat that diazepam?
Yep. So the benzodiazepine or the diazepam or the Valium, whatever name you want to use, that is going to obviously cause relaxation, right? So if I increase the levels of diazepam, which happens if you take it with a PPI, you're going to get high levels of the diazepam, which can cause too much CNS suppression, leading to drop in LOC, coma, seizures, respiratory or cardiac arrest. Okay. Did that help? Anything else I can do?
No.
Okay, perfect. Does anybody know what the antidote to benzodiazepine poisoning is or overdose?
As a Narcan?
It is not Narcan. That's an opioid.
Oh.
It is
It's gonna be a
flumethazine.
stimulant, right?
I'm not sure about the class that it comes from. I just know the name. It's called flumazanil. So it has some sort of stimulating property, yes, but it's flumazanil. So I was just curious. I don't know why I brought that up. All right. But we're good with this one. Then my PPIs here. Whoops, sorry. I don't know why I just did that. All right. PPIs are generally well tolerated. They work the best and they're well tolerated. Okay. However, when you use them for a really, really long time, okay, you get like almost no stomach acid, right? Because every 24 hours, usually again, these last 24 hours. So, or at least 12 hours. So they have a really long, like lasting duration. You get no stomach acid for the amount of time that they're working. So if you take it for years and years and years without getting a lot of stomach acid, then you lose the ability of the stomach acid killing those pathogens that we talked about earlier. So what would that make me more at risk for? in a body.
Pneumonia?
GI
Pneumonia.
infections.
Not just GI infections, whole body infections. Because the GI tract is just their route to the rest of the body.
So it
'Cause,
becomes systemic. Why? Because it's traveling through the blood.
yep, it can. Yep. Or it could just it could like not cause an infection until it gets to a certain organ. It just depends. But yeah, there definitely isn't a risk of sepsis. Yep. So is that a pretty dangerous adverse effect?
Yes.
Yeah. Okay. Does anybody have any questions about that one? Okay. All of these drugs end in prazole. Okay, they end in prazole. I want you to know Prevacet. I want you to know omeprazole or Prilosec. I want you to know pantoprazole or Protonix. All right, and I want you to know Nexium. Okay, so only for Prilosec and Protonix do I need you to know the both names, the generic and the trade. Okay, but I also want you to be familiar with Prevacet and Nexium because those are also used all the time. Okay.
I thought they disconnected, not
Oh, yeah.
disconnected, but discontinued Nexium.
Did they?
I don't see it on the market like that no more.
Okay, I'll have to look into that. Thank you.
Ain't Protonix are intracoated where it can't be crushed?
It can be most of the time. Yeah, it comes in a powder, and you have to mix it up in the flush and then give it IV push.
Okay.
Yeah, that's usually like if you're in the hospital, how it's usually going to come. That's really the only way I've ever given it. So I'm not sure what would happen with the oral version. Any other questions, concerns about this? Okay. I briefly just want to talk to you about Carafate. Does anybody know what Carafate does?
Treat ulcers.
Okay, it treats ulcers because again, it increases the mucus that gets made. Okay, because if you remember back to that first slide, the mucus did what when the stomach made it?
Lines the stomach.
Yeah, like it protects the stomach lining, right? So if you had an
Right.
ulcer, that's like a crater in your stomach lining, right? Like it's almost being eaten away at. So anytime that you have like food in there, the stomach acid is going to come and it's going to hit that ulcer, causing pain. So if I give you a more of a mucus layer covering it, when I go to eat, the food won't necessarily hit that ulcer, or the stomach acid won't hit that ulcer. Does that make sense?
Explain that one more.
Okay. Usually you take Carafate before a meal. All right. And this is why. Because when you have an ulcer, you have like a little cutout of your GI, of your stomach lining, right? Like it's almost like somewhat like it's been worn away, it's been eaten away at from inflammation and or H. pylori or something like that. So you get a little crater in there. The rest of the stomach lining pretty much tolerates the hydrochloric acid, but that punch out, that crater, that really when you wore away the stomach lining, you kind of wore away the mucus too. So when you eat and you get the hydrochloric acid washing through your whole stomach, it's going to hit that crater or that ulcer and it's going to hurt, whereas the rest of your stomach lining is protected. Does that make sense so far?
Yes.
Okay. So what Carafate does is it goes and it lines that ulcer so that when you eat, the stomach acid doesn't hit it, so that you don't feel that pain.
That makes
And
sense.
it kind of protects the ulcer from getting worse from the acid hitting it, right? Because the more acid that hits it, the more it's going to wear away at it as well. So this is
So
why
it's
you
just
take,
being protective. So that
yeah,
that Carafate just coming in being protective over that
yes,
ulcer. Okay.
yeah, exactly, yeah. And that's why you take it before you eat, because when you eat is when you're going to get the most hydrochloric acid produced to break down your food. Okay. Questions here? Okay. This one's pretty well tolerated. It doesn't cause a lot of issues, just, general GI things, nausea,
Oh.
constipation, dry mouth. Okay. Yes.
Miss High, can you run that one more time? By the Carafate, it protects the lining of the stomach due to the ulcer?
Yeah, because you have the ulcer first, and the ulcer is a wearing away of your stomach lining, right?
Mm-hmm.
Okay. So when you have that stomach lining worn away, those mucus cells that were there to protect it against the hydrochloric acid have been worn away as well. So in
Okay.
that little pocket of that ulcer, there's nothing left to protect it from the hydrochloric acid when you eat.
Oh, okay.
Yeah, so what this does is it goes and lines it for you since the cells that were there to do it have been destroyed.
Classroom, not okay. Oh, sure. Okay. Let me know. Okay.
Questions? Does that answer your question? Any other questions
Yeah.
about this slide? Okay, perfect. All right, that's basically just Carafate. I just kind of wanted to mention what that is because you probably will see a lot of patients, if you haven't already, that take that. All right. This one right here isn't super crazy. I do call it cytotactic just because, I can't pronounce drugs. And this one's easier to say. So if I'm going to ask you a test question, it would be cytotech. Okay. This one is just basically used NSAIDs, because what was the black box warning for NSAIDs with the GI tract?
It could cause GI bleed.
Yep, GI bleed and ulcers. Okay. So basically, what this does is it helps protect the stomach from ulcers or GI bleeds from NSAIDs. Okay. Simple enough.
Yes.
Okay. That's all I really wanted you to know. The rest, just read through the nursing implications, nothing crazy. Any other questions or concerns about this chapter? Any questions, concerns?
No.
No? Okay. Let me see. It is 8:05 right now. Why don't you guys come back at 8:15? Just take a few minutes, okay? Because I know that was a lot. And we'll finish the other chapter. Okay. It's very short. Sound good? Okay. So come back at 8:15, okay?
Okay.
Okay. Are we ready to do the next chapter?
Yes.
Okay, let me share my screen. All right, so this is going to be chapter 52. We are going to do my antiemetics. What are those used for?
Nausea and vomiting. Yeah.
Yep, nausea and vomiting. Okay. It doesn't matter what causes the nausea and vomiting, whether it just be, I don't know, like a GI bug, whether it be like surgical from anesthesia, whether it be chemotherapy induced. It doesn't matter why. This can kind of help with all types of reasons why you have it. Okay. So does anybody know what the vomit center is in the brain? Has anybody heard of that before? The vomit center.
I have it.
Okay. It's super weird name, I know. However, what this is, it's the place in the brain that tells me that I'm nauseous. So it doesn't matter, again, what that causes, whether it's I smelled something disgusting and then that smell like signal went to my brain, whether it might be like I just saw like a child vomit, so then that's going to make me want to vomit. I deem that gross. That stimulus goes to my brain. Maybe I ate something gross. That stimulus goes to my brain. Does this kind of make sense? Whatever is causing the vomit or the want to vomit, that like nerve signal goes up to this part of my brain, the vomit center. And then therefore the vomit center is like, okay, we must vomit. And then it sends that basically tells my vomit reflex in my throat to go ahead and vomit. Okay, in my GI tract and all that kind of stuff. Then it tells it to, okay, now you need to start, forcibly emptying your, content. Does that make sense?
So when you're having too much liquor, basically,
Yep.
that's them two things working together that's gonna make you basically start vomiting.
Yeah, so let's use that example. So you drank too much. So then my body tells my brain, I need to get this out of me, right? So then that is kind of like the stimulus, right? That's why I need to vomit. So then the vomit center of my brain is going to be like, okay, let's vomit. So then it's going to tell the brain's going to tell my GI tracts, okay, now you got to empty out, and then you're going to start to vomit.
Oh.
Yep. Any other questions about this? Good example. Okay. The only reason I say that is because, again, we know why we take an antiemetic, okay, nausea, vomiting. But what we just saw is going to, with the vomit center, is going to be our mechanism of action, okay? I have these groups a little bit differently. There's a bunch of different types of antiemetics. So, and each of those groups has a different mechanism of action. So I have the class or the type of antiemetic listed with the way that it works and with the names of that group. Does that make sense the way that I'm organizing this? Because there were so many of them.
Can you say that again?
Yeah. So there's a bunch of different types of antiemetics. So I just have them grouped by type here because they're divided by the ways that they work. And then I just have the names in those groups of the antiemetics under it.
Oh, yes, that makes sense.
Okay, yeah, just because there was a lot of information, so this was the best way I could find to organize it. Okay. Just didn't want you to look at this and be like, what is she doing? Okay. So the first type of antiemetic is going to be my anticholinergic. Do we remember that word anticholinergic? You probably never want to hear it again.
Parasympathetic, right?
Yep, it blocks the parasympathetic, right? What was the parasympathetic doing? It's rest and digest, right? So it is enhancing or telling my GI system to work. So by blocking the digest part of rest and digest, I'm going to not allow the vomit center to tell my stomach, hey, you need to throw up. Does this make sense?
Yeah.
Okay. The name for that is scopolamine. Okay. I know we use scopolamine for a couple different things, but again, I know you guys have heard of like using it probably as like a motion sickness patch or something like that, right? This would be why. Okay. Are we good to move on to the next one? Okay. So this one is an antihistamine. So if you don't know any antihistamines, something, okay. Like if you are out of like Pepsid or whatever you have, and the only thing that you have is Benadryl, you could use that to help with your nausea and your vomiting. Because what that does is it prevents my cholinergic system. Okay. So the cholinergic system can kind of, not that it starts rest and digest. I know. Oh, I'm sorry. Let me rephrase that. So antihistamines work similarly, to my anticholinergics. Let me say it that way. It makes more sense that way. So antihistamines work very similarly to what we just talked about in my anticholinergics. Otherwise, it's pretty much the same thing. It's blocking my parasympathetic. Okay. Sound good?
So you saying that anticholinergic and antihistamine work similar?
Similarly, yes. They both, in this particular way with the nausea and vomiting, they're both stopping the parasympathetic nervous system or my rest and digest.
So what would be the difference between the two? Or have you not got to that
Um,
yet?
Oh, no, that's a good question because anticholinergics are just used to block my cholinergic system or my parasympathetic nervous system. Antihistamines have a lot of different functions. They stop like my allergy symptoms, right? They stop my histamines, my immune response, but then they can also do this. So that would be like the difference. Antihistamines work in other ways as well. Does
Okay,
that
but they
help?
just serve the same purpose when it comes to emesis though. Like
Exactly. Yep.
the
Yeah,
okay.
exactly.
Okay.
Yep, you got it, ma'am. Okay. And then the names I want you to know, you don't need to know this name, but I do need you to know Dramamine. Okay. If you didn't know, Dramamine is an antihistamine. Okay. I do need to know diphenhydramine and Benadryl. Okay. I do need you to know meclizine and Antivert. Has anybody heard of that before? What else is that used for?
Dizziness.
Yep, dizziness, right? Or vertigo. Okay. Kind of the same thing because it kind of helps work in the brain as well. Okay. And then you should be familiar with this one, but I'm not going to quiz you on it. The hydroxine or the Vistaril, not going to quiz you on it, but just be familiar that a lot of people do use this one. Okay. Sound good? So Dramamine, Benadryl, and Antivert, but for these two, know both names, meclizine and diphenhydramine too. Okay. Good there? Okay. The next one is going to be an anti-dopaminergic. So that literally just means that we're stopping dopamine from working in the brain. We're reducing the amount that dopamine can work in the brain. Okay. What is dopamine? What is that?
Is it the hormone that like make your body become more excited?
It makes you more excited. It's not a hormone, it's a neurotransmitter. So close. Okay. Everybody knows what a neurotransmitter is in the brain? Or do you need me to go over what that is?
Ain't they don't they like fire or off or they like
Yeah,
send
they
messages and stuff like that?
Yeah, exactly. Yeah, they're the chemical that helps the nerves send messages to each other. Okay. And dopamine, you're right, is an excitatory neurotransmitter where it basically amps the body up. Um, and so if that's going to amp the body up, it's also going to amp up the GI tract, right? So a way to take that down a notch is to stop as much dopamine from coming through to excite the GI tract, which again will help me not vomit. Does this make sense?
Yeah,
Yeah,
so
so it's just stopping the body from reacting, basically.
To dopamine, yep.
Okay.
so
Yep.
when your body, like when a person has to vomit and they
Mm-hmm.
keep getting that little gurgly, like it want to come up feeling, is that what you referring to? Like how
Um,
your stomach just keep going?
like the dry heaving.
Yes, something like that.
Yeah, the dry heaving is usually like the preemptive to vomiting. So this could help with that before you actually get to the vomiting too. Yep.
Can I
Okay.
go
Okay.
back for a second?
Yes, ma'am.
For the hydroxyzine, wouldn't it be the Atarax more so than the Vistaril? Like I thought, the Vistaril was more so for like the anxiety and things of that nature, where the Atarax, the tablet form, was for more of like the itching, the high, like
Yes.
they were.
You are correct, but the visceral can also be used because again, we said that the antihistamines have like a couple different functions. When it comes to the antihistamine, this one works really well because the visceral is used for like more anxiety type things. It works better in the brain.
Okay.
Yeah, does that
All
help?
right. Yes, thank
Okay,
you.
perfect. Yeah, no, thank you for asking. All right, any questions about how the anti-dopaminergic works before I tell you the names? Okay. Um, the only names I want you to know is compazine and Phenergan. Have we heard of these? Hopefully you have at least compazine, right?
Won't
Yes.
they use one before the other? Be like ain't promethazine, which is phenergan, ain't that's like if it get like so severe?
Yeah, I think yeah. Compazine is pretty much handed out like candy when you have a GI tract like bug. But yeah, Phenergan they usually reserve more for like the hospital. So you are correct. Yeah.
Okay.
Okay. Yeah. And then I just need you to know this one just because it's so dangerous. Doperidol is a very, very dangerous form of an anti-dopaminergic because it can cause cardiac dysrhythmias. So sometimes it's even banned. Like some hospitals don't even allow you to use it. Okay. So just know this one just because of the bad thing that it does. Okay. Good there. Okay. The next one, I have never heard of these. So I'm just going to briefly tell you about them. Yes, you do have to know them, but you probably, again, won't have heard of them. They're neurokinin receptor antagonists, if I even said that right. These work in the brainstem, okay? Because what does the brainstem control usually? Do you know?
Ain't
Um,
that where our CNS?
Yeah, everything from the CNS does go through the brainstem before it can get to the spinal cord. But the brainstem is more responsible for all of your autonomic processes. So, again, my sympathetic and parasympathetic nervous system. So, it can again help inhibit the parasympathetic nervous system in your brainstem. Okay. And this one works really well with chemotherapy induced vomiting. Okay. Questions about that? So again, it targets the parasympathetic nervous system, but just particularly the part that's in the brainstem. Okay. Just be familiar with this one. I'm not even going to attempt to say it. And this one. Okay. If I did ask you a question, it would either be the class name or it would be these two. Okay. Questions, concerns about the neurokinin ones. Okay. The next ones you have definitely heard of. Who's heard of Reglan? Right. So this is called Breglin is a prokinetic drug. That is the type of antiemetic that it is. And it basically works very similar to the anti-dopaminergic, is it blocks dopamine. Okay. They just block dopamine in two different ways. Okay. Questions about this? Is
No.
everybody? No? Okay. Okay. And then if you use Reglan for a long time, it can cause tardive dyskinesia. What's that?
Like uncontrollable movements of the face, like lip smacking and or tongue smacking,
Yep.
or
Or
repetitive
usually like,
movement.
yeah, like maybe tics of the face or hand movements. Yeah. Yep. So if you use this for a long time, you can develop that. And is tardive dyskinesia curable? Is
No,
it?
No.
can it just be like controlled? Like
It
it could
can't,
be like try to control it, but it's
yes.
not
So you
curable.
can't cure it, but you can treat it. There are medications made to treat it. One of the most common ones I know of is Ingrezza. There's a lot of commercials for that one. Um, and then what other type of medication usually causes tardive dyskinesia? Like where do we
Like
typically see it?
antipsychotics?
Yeah, my antipsychotics, like my Seroquel, my Risperdal, my Haldol. Okay. That's usually where we see it. This is kind of an odd place to see it, but it can happen here with long-term use. Okay. Are we good with this?
Yes.
Okay. Okay. The next one is going to be a serotonin blocker. Okay, we're probably pretty familiar with serotonin from SSRIs, like our antidepressant medications like Prozac, um, Paxil, Zoloft, all those kind of ones. So what does serotonin do? Serotonin's a neurotransmitter, but does it excite you or does it kind of calm you?
Um,
Does it calm you?
because dopamine is your excited one, so serotonin calms you, right?
It actually does not. Serotonin actually excites you as well.
Oh,
Okay. GABA is one of the biggest calming ones. Okay. So serotonin also excites you just like dopamine does. Okay. So keep that in mind. So again, if it excites me, it can also excite my GI tract, right?
yeah.
Okay. Yeah. So we're gonna block it, right? We're gonna make it so that the body can't respond as well to serotonin. Okay. And the one that we are most familiar with is again Dancertin or my Zofran. Okay. So that is how Zofran works. I know that's probably the one that we're all familiar with. That actually blocks serotonin. Okay. And then this one, my Tetra.
You're frozen.
This is going to be like your marijuana type, or it's made
Can
from
you
marijuana.
repeat all of that? You just went out.
Oh, sorry. So the last one here is my tetrahydrocannabinoids. So this one is especially this part right here may look familiar. The cannabinoid part, a non-THC part of marijuana. They make it in a pill. And who's heard of Marinol?
I have it's like a narcotic that they refrigerate. Don't it like help with the um appetite?
Yeah, it helps with appetite. Yep. Because it is refrigerated and it's kind of more controlled because it's made from marijuana. Okay. So this one just helps stop the effects of the cerebral cortex. The cerebral cortex is like the biggest part of your brain that has like your frontal lobe and my temporal lobe, like all of the lobes that do like the important stuff. And that's where your vomit center is located. Okay. So basically, it's just going to basically kind of inhibit the vomit center itself. Questions about that?
I have a question about the Zofran. So you said that it blocks the serotonin, so that means that it's blocking the feeling to vomit.
Correct, because we're hoping that it's blocking the serotonin that is going to excite your GI tract. But it may excite or it may block the serotonin in other levels or other locations too. Does that help?
Yeah.
Okay. Any other questions about these groupings here? The classes, what they do, or the names of the drugs in them?
Yes, I was just trying to like differentiate the things. So your antiemetic is your class. What do you, is these
So
like the drugs, the neurokin receptor agonists? What?
these would be your subclasses.
Your
Yep.
subclass. Okay,
Yep.
got it.
You are correct, ma'am. Yep. Subclasses. Okay. All
Okay.
right. So there's no contraindications. Okay. So we're good there. Now I'm just kind of talking about all the antiemetics in general. Do you understand that? So I'm not just talking about one of the subclasses, I'm talking about everything together. Okay. Um, However, with the interactions, some of the subclasses do tend to have their own. Okay. Um, how do I want to? If you give an anticholinergic class,
You're frozen.
if you mix these two subclasses together, you could get a drying
You
effect.
went out.
Um, antiemetic with an antihistamine antiemetic, you could get a drying effect. Because they both, again, we good there?
Sorry,
You
can you
said
repeat
that.
that again? It just keeps going in and out.
Goodness gracious. I'm so sorry. Okay. Um, if you take an anticholinergic with an antihistamine, you have a high.
No.
Oh my goodness gracious.
As soon as you start saying it, it goes.
It goes out. Of course it does. Okay. I'm gonna have to get my Wi-Fi looked at. I'm so sorry. Um, all right, but if you take an anticholinergic with an antihistamine, you get a drying effect. Did you hear that one?
Yes.
Okay. Because they both decrease the parasympathetic nervous system. Are we good there? I didn't go out, right? You can still hear me.
Yeah.
Okay. Oh my goodness gracious. I'm so sorry. Um, if you take an
Got a
antihistamine,
question.
yes.
So on here it also says antidepressants. Are we ignoring that or no?
Yeah, we're ignoring it. Yeah. Because I just want you to
Thank
focus
you.
on these two. Yep. Yep.
Okay.
Yep. Okay. So if I take an antihistamine with any other type of drug that causes CNS depression, I will get too much CNS depression. Does that make sense?
Wait, what?
So
Antihistamine.
if I take an antihistamine antiemetic with any other medication that causes CNS depression, like slows down my brain, right? I am going to get increased, even more increased CNS depression as a result of mixing those. Does that make sense?
So do that mean like a Benadryl with a Xanax?
Yeah, exactly. That could be a Benadryl and a Xanax because Benadryl makes you fatigued, right? And then the
Uh-huh.
Xanax also makes you fatigued, so you could get way too much of this CNS effect. It could be the
Okay,
same.
thank you.
We good?
Yes, I got it. Thank you.
Okay, yep, perfect. All right. And then if you take Reglan with alcohol, you also get CNS depression. Simple enough? If you take Reglan with alcohol, you also get CNS depression. Okay. Did you hear that?
Yes.
Okay. Sorry, I'm just hyper paranoid now. Okay. Same thing if you take antidopaminergics with a CNS depressant medication, you will get too much CNS depression. Okay. So basically, if you take an antihistamine, Reglan, or an antidopaminergic with a CNS depressant, you will get increased CNS depression. Simple enough?
Yes.
Okay. You can ignore this last one. Okay. And then all antiemetics together can cause these adverse effects. Okay. So we can get dizziness, we can get fatigue, we can get disorientation or confusion. What does this all give me? A what risk? A risk of what?
False.
False. Okay. Same with hypotension, right? Could give me orthostatic hypotension, which could make me fall. Okay. I'm just trying to pick out the big ones. It could give me tachycardia. All right. Dry mouth. And then this is the big one. It can give me a prolonged QT. Does anybody know what that is? A prolonged QT.
It's on your echo cardiogram from your heart, which indicates can it be like a heart
Repeat that.
attack, myocardial infarction?
Close. You do see it on an EKG, but basically it extends your heartbeat. So when your heart's beating, it like slows down your heartbeat and stretches it to last longer. Is that safe?
No.
No. So it's going to lead to like dizziness. It's not going to make your heart pumping as effective. Does everybody kind of understand this? It's similar to a dysrhythmia. Okay. Um, for example, I have IBS. So when I had an IBS flare up, I was taking a lot of Zofran around the clock. Okay. I wasn't like overdosing or anything, but I took it around the clock and I ended up getting really, really dizzy and almost falling over at work. And I had to go to the ER. And guess what they diagnosed me with?
The prolonged QT interval.
Yep, because they did an EKG. Does this make sense? So, moral of the story, I can no longer take Zofran. But this is a huge, dangerous adverse effect. Okay. Does anybody have any questions about anything else that's left on this slide? Yes. You say no, or did you have a question? Sorry.
No.
Okay.
So
Perfect.
it's the
Yes.
so is the adverse effects for all the subclass
Yes.
antiemetics?
Yes. All of them together. Yep. All of them together. I just kind of grouped them all together. And here's your antiemetic tray. Okay. Don't worry about this one. You can skip that one. Ginger, just really quickly, this is a herbal antiemetic. Sometimes this works, won't. The only thing I really want you to know about this is that it can cause bleeding. Okay. You good there?
Yes.
Okay. And then just read through the nursing implications, and I think we're good. Does anybody have any questions or concerns?
Are you still
I
doing
do.
that Zoom tomorrow?
I am, yes.
Okay. And what time was that again?
2:40, or sorry, 2:15 to 3 o'clock.
Okay.
Yep,
So I just had one question about the adverse effects again. You
correct.
say
Yes,
the adverse effects is for all of the antiemetics and the subclasses
correct.
or just the subclass?
Nope, everything.
Okay,
Yep,
all right.
you are correct. Anything else I can help you with before we log off here? All right, I am recording this, and then I am having the tutoring session tomorrow. So if you want to use that to go over the tests, we can. If you want to use it to go over questions or both, if we have time, do that. Okay. This is being recorded, so I am going to post it. Okay. Probably tomorrow once it's loaded. All right. So everybody good? Okay. I will see you tomorrow at the tutoring session if you want to come. All right. Have a good night.